Today we have nigh on an hour's worth of morphology to share with you. So we're going to get on directly with that now. And Sasha is going to show you the video. And after that, he will be in charge of the questions and answers. We have a good faculty with you. But Sasha, start us off with the video. We had the introduction to congenitally corrected transposition. And I told you that this lesion, in essence, was the triumph of sequential segmental analysis. So this week, we're going to try to put into practice what we shared with you last week. You will remember, I hope, this picture. It's from the Atlas of the Baron von Rokitansky. And as far as we are aware, it is the first known illustration of congenitally corrected transposition. I pointed out to you last week that it was serendipitous that Rokitansky took the picture, made the etching in such a way that it would be directly relevant to modern day echocardiographers. So you're all recognized, we're looking from the apex of the ventricular mass towards the short axis of the ventricular base. And we can recognize there the morphologically right atrium. We can see its appendage. We can see the morphologically mitral valve. And since we know that the valves go with their ventricles, we take advantage of valvular morphology when it is there. That tells us the morphologically left ventricle is right-sided. And they're deeply wedged between the leaflet of the mitral valve and the septum. We find the pulmonary outflow tract. And that wedging of the subpulmonary outflow tract is going to become important today when we discuss the significance of conduction problems in the setting of congenitally corrected transposition. If we look at the other side, we can recognize the underside of the morphologically left atrium, and there we see the morphologically tricuspid valve. We note its septal attachments, so that tells us that the morphologically right ventricle is left-sided. And there, arising anteriorly from the morphologically right ventricle, we have the aorta, which, as in the majority of cases of congenitally corrected transposition, is anterior and right-sided. So what we are looking at is discordant connections between the cardiac segments. And you will remember that last week I emphasized to you that the essence of sequential segmental analysis was that first we analyzed the components of the segments and then we assessed how they were joined together. So what we are looking at today is the combination of discordant atrioventricular connections and discordant ventricular arterial connections. And it is the combination of the two discordant connections that cancels each other out, hence the congenital correction of the circulation. What we're going to show you is that we can find this either with usual atrial arrangement or rarely with mirror imaged atrial arrangement. And so that excludes what we're going to call the close cousins, and we'll introduce these close cousins to you at the end of our presentation. But to set the scene, we're going to be looking at other examples of left-handed ventricular topology that don't fulfill the definition of congenitally corrected transposition. And we're also going to look at examples of hearts with discordant atrioventricular connections, but which have other ventricular arterial connections than the discordant ones. And this means, of course, that in that setting, strictly, there is no transposition. So again, a close cousin. So what we are looking at is this arrangement. Morphologically right atrium is connected to the right-sided morphologically left ventricle, which gives rise to the pulmonary trunk. The blood comes back to morphologically left atrium and then goes to the morphologically right ventricle, which is left-sided, and that gives rise to the anterior and left-sided aorta. And that is what we find in the majority of cases that have usual atrial arrangement. But remember, we can have exactly the same thing when everything is mirror imaged. So here we now have the left-sided morphologically right atrium, and then now in the setting of discordant atrioventricular connections, the left ventricle is where we expect it to be. And it gives rise to the pulmonary trunk. So the blood comes back now to the morphologically left atrium, but because of the mirror imagery, that is now right-sided. But again, because we are talking about mirror image congenitally corrected transposition, the morphologically right ventricle is also right-sided. Here is one of the potential problems for nomenclature. It gives rise to an anterior and right-sided aorta. So when we have congenitally corrected transposition in the setting of mirror imaged atrial arrangement, it is D-transposition, it is D-loop transposition, but it is still congenitally corrected because we have the combination of discordant atrioventricular and discordant ventriculo-arterial connections. So this is what we are going to be looking at today. And so we know that the double discordance corrects the circulatory patterns. So potentially, these patients, these individuals, can live a full life. And indeed, genetically corrected transposition has been discovered as a chance event in autopsies of patients at the age of 90 years. And that means that in that setting, the ventricular septum will have been intact. So now Diane is going to show you the features of congenitally corrected transposition with intact ventricular septum.
This heart has congenitally corrected transposition. The aorta lies to the left of the pulmonary trunk, and it has been cut just prior to the bifurcation of the brachiocephalic arteries. We see the superior and inferior caval veins joining a morphologically right atrium. So here is the blunt triangular tip to the appendage and the broad attachment with the venous component. Looking inside of the right atrium, we see the characteristic pectinate muscles around the right atrioventricular junction. Here's the coronary sinus and the flap valve at the floor of the oval fossa. The oval foramen is probe patent in this case. Guarding the inlet, we have a morphologically mitral valve, which will always travel with the left ventricle. It's supported by paired papillary muscles, and there are no attachments to the septal surface. The morphologically right atrium is connected to a morphologically left ventricle, so that we have discordant atrioventricular connections. There are the fine crisscrossing apical trabeculations that are the morphologic determinant of the left ventricle. We can see that smooth septal surface towards the outlet component of the ventricle. And here, there is fibrous continuity between the mitral valve and the pulmonary valve. This is the pulmonary trunk exiting the left ventricle and dividing or bifurcating into the right and left pulmonary arteries. So that now we have a discordant atrioventricular and ventriculo-arterial connection, but the flow of blood is still going the right way around. Looking at the left side of the heart, we see the pulmonary veins draining into this left-sided atrium, which we can confirm is a morphologically left atrium with its tubular appendage and the narrow attachment to the venous component of the atrium. When we look inside, the atrial vestibule is smooth. Here is the left side of the flap valve, which you can see is probe patent, and the pectinate muscles are confined to the appendage. So this is a morphologically left atrium. The inlet is guarded by a morphologically tricuspid valve that has one of the associated malformations seen with congenitally corrected transposition, namely an Ebstein's malformation. There's also a bit of dysplasia to this valve. It is a morphologically tricuspid valve because there are attachments to the septal surface and attachments to papillary muscles. the tricuspid valve will always travel with a right ventricle, so that on the left we do have a morphologically right ventricle with its coarse apical trabeculations. So here we have discordant atrioventricular connections on the left side as well. Within the outlet, the aorta is supported by a complete muscular infundibulum. So again, discordant atrioventricular and discordant ventriculo-arterial connections. This ventricle does exhibit left-hand ventricular topology, as I can only place the palm of my left hand on the septum with my thumb in the inlet and my fingers in the outlet. The interventricular septum is intact in this case with congenitally corrected transposition.
So now you've seen that on occasion, congenitally corrected transposition can have an intact ventricular septum, and potentially it can sustain circulation for a full lifetime. But let's go back to von Rokitansky's picture, because look at that morphologically tricuspid valve. It is dilated. And here we have one of the problems that we find in the setting of congenitally corrected transposition. And Diane showed you that in her case with an intact ventricular septum. The Achilles heel of the double discordance is the morphologically right ventricle, and anything adding to the woe of the morphologically right ventricle will mean the situation and the prognosis gets worse. And so we know that in most instances, the combination of discordant atrioventricular and ventricular arterial connections is associated with a trilogy of associated malformations. In the majority of cases, in fact, the ventricular septum is deficient, so we have a ventricular septum defect. Oftentimes, we have obstruction in the outflow tract of the morphologically left ventricle. And as Diane has shown you, in the majority of cases, there are lesions of the morphologically tricuspid valve, and she has shown you Ebstein's malformation. And then the situation is made worse by problems in atrioventricular conduction. So we're going to discuss all these features now in what remains of today's session. So we're going to start off by looking at the ventricular septal defect. And you will not be surprised to know that, as in the normally connected heart, the majority of these defects will be perimembranous. Some can be muscular, they can open to the inlet, they can open apically, they can open to the outlet. And on rare occasions, the ventricular septal defect can be juxta-arterial. Now, when we categorize the ventricular septal defect, we should take note of this manuscript that was published relatively recently, as you see, 2020. And this comes from Lucille Hoyel, the outstanding cardiac morphologist, pediatric cardiologist, who is now working at the Necker Hospital in Paris. Previously, she was at Marie-Lennelong Hospital in Paris, and she has an outstanding archive of congenitally malformed hearts. And with her colleagues, she pointed out that when we categorize the ventricular septal defect in the setting of congenitally corrected transposition, we should do that from the stance of the morphologically right ventricle. And she is entirely correct in making this assertion. So now we should look at the ventricular septal defect, and we should assess those features from the stance of the morphologically right ventricle. And we should then recognize the defects that are perimembranous, will have fibrous continuity between the mitral and tricuspid valves, posterior inferiorly. Those, as viewed from the right ventricle, that are muscular, will have exclusively myocardial borders. And then again, those viewed from the right ventricle, in which the defect extends such that there is fibrous continuity between the aortic and pulmonary valves, will be juxta-arterial. Remember, in this context, however, when we think about the ventricular conduction system, the conduction system is in the roof of the morphologically left ventricle. And that means that it is relatively protected from the morphologically right ventricular side, but in the majority of cases which have usual atrial arrangement, that is on the other side as far as the surgeon is concerned. But it is also true that for a long time we categorized the ventricular septal defects in this way, looking at it from the stance of the left ventricle. And in this particular heart, we have a large defect. It transpires that it is confluent, but when we look at the defect, it has mitral to tricuspid continuity, telling us that it's perimembranous. But we're going to emphasize this fact again shortly because of the deep wedging of the pulmonary trunk between the mitral valve and the septum. The atrioventricular node is no longer within the atrial septum. It is at the floor of the right atrial appendage, anteriorly within the mitral valve orifice, and the conduction axis swings anterocephalad relative to that subpulmonary outflow tract, and it is in the roof of the left ventricle. And my very good friend Jan Quachenborg, who started his career as a cardiac surgeon in the Netherlands, finished it for many years working at Columbia University in New York, took advantage of this fact, as you see here, and when he was closing the ventricular septal defect, as they used to do in congenitally corrected transposition, he would place his sutures through the ventricular septal defect, place them from the morphologically right ventricular side, and so avoid conduction system.
In this segment, we're going to look at ventricular septal defects, but I think it's worth mentioning some of the other subtle variations that we can see in this group of hearts with congenitally corrected transposition. Here, the apex of this heart is roughly to the midline, and you'll note that the heart even has a roughly square position with almost a straight or flattened apex. The aorta and pulmonary trunk are related such that the aorta is nearly directly anterior to the pulmonary trunk and a bit leftward. So when we look at ventricular septal defects in the normal heart, we look at them from the right ventricular aspect, and that's how we establish their borders and their geography. So it only makes sense that in hearts with congenitally corrected transposition, we should look at the same borders and geography from the morphologically right ventricle. So here's our morphologically left atrium with its tubular appendage, pectinate muscles confined to the appendage, and a smooth atrial vestibule. The morphologically tricuspid valve is guarding the inlet to this morphologically right ventricle. We can see there are septal and papillary muscle attachments. And then the right ventricle has its characteristic coarse apical trabeculations, which are its morphologic determinant. So this ventricular septal defect is a central perimembranous ventricular septal defect, so that it lies just behind the zone of apposition between the septal leaflet and, now in this heart with congenitally corrected transposition, the posterior most leaflet rather than the anterior superior leaflet. And there is our medial papillary muscle, the subaortic muscular infundibulum within the left-sided morphologically right ventricle. So again, we have discordant ventriculo-arterial connections. The septomarginal trabeculation is giving rise to the cephalic arm, which rises up to become part of the muscular infundibulum, and the caudal arm, which in this case extends to reach the inner heart curvature, so that the supraventricular crest is inserting normally between the limbs of the septomarginal trabeculation. As I mentioned before, this is the medial papillary muscle, and the borders of the ventricular septal defect tell us that this is a central perimembranous ventricular septal defect, so that the caudal arm of the septomarginal trabeculation reaches the inner heart curvature, and there is fibrous continuity between the tricuspid valve and the mitral valve along the posterior inferior border of the defect. If we look at the defect from the morphologically left ventricle, here we see the fibrous continuity between the right-sided morphologically mitral valve and the arterial valve, which in this case is the pulmonary valve. And there is our ventricular septal defect. The posterior inferior border shows us that there is fibrous continuity between the mitral valve and the tricuspid valve. This heart also has a ventricular septal defect, but I wanted to first point out that the apex of this heart is pointing to the right. Also, look at the relationship between the aorta and the pulmonary trunk. They are virtually side by side, with the aorta a bit anterior and leftward of the pulmonary trunk. I'm going to go right to the outlet portion of this left-sided morphologically right ventricle. You can appreciate the coarse apical trabeculations. The septomarginal trabeculation is here, with the cephalic arm rising up to be incorporated into the subaortic infundibulum. The caudal arm does not reach the inner heart curvature, and so the ventricular septal defect lies within the limbs of the septomarginal trabeculation, so that this is an outlet ventricular septal defect. The tricuspid valve and the mitral valve are in fibrous continuity along the posterior inferior border. Looking at the left side of this defect shows us that fibrous continuity along the posterior inferior border between the mitral valve and the tricuspid valve. And the fibrous continuity in this specimen is a bit broader than it was in the previous specimen. We're looking at another heart with congenitally corrected transposition, that is an explanted heart, so that the majority of the atriums and arterial trunks have been previously removed. The morphologically left atrium is connected to a morphologically right ventricle on the left side, and guarding the inlet is a tricuspid valve. You can see that the tricuspid valve is mildly thickened, and that there is a defect beneath the septal leaflet of the tricuspid valve. There are chordal attachments along the crest of the ventricular septum. Looking at the outlet component of this morphologically right ventricle, here we see that there is a prosthetic aortic valve previously placed, and this is our subaortic muscular infundibulum. The septomarginal trabeculation is here, with the cephalic arm rising up to be incorporated into the muscular infundibulum. The caudal arm in this case does not reach the inner heart curvature, so that along the posterior aspect of this defect we have fibrous continuity between the mitral valve and the tricuspid valve. This defect extends into the outlet of this right ventricle, and remember, I also said that it was extending to the inlet, so beneath the septal leaflet of the tricuspid valve. This defect is then consistent with a confluent defect. Looking at it from the left ventricular side, you can see the crest of the ventricular septum here, and that portion of the left-sided tricuspid valve that is straddling and overriding the ventricular septum. Here is the fibrous continuity between the mitral valve and the tricuspid valve along that posterior inferior aspect of the defect. Also, there is the fibrous continuity between the mitral valve and the pulmonary valve. So I'll just reiterate again that we should describe ventricular septal defects as seen from the left-sided morphologically right ventricle, just as we describe them in the normal right ventricle from the right ventricular side.
So Diane now has shown you perimembranous ventricular septal defects. We don't have any hearts to show you with pulmonary stenosis, but I can tell you about the lesions that produce pulmonary stenosis. It can be valvar, and then, as it is the pulmonary valve, we have dome pulmonary stenosis. There can be a fibrous shelf. I'm going to show you a picture of that very shortly. But one of the features we see in congenitally corrected transposition is tissue tags. And here's a very nice picture of such a tissue tag that is blowing into the subpulmonary outflow from the high pressure morphologically right ventricle. There it is. It's producing subpulmonary stenosis. On occasion, cardiac surgeons have unwrapped these tissue tags and have used them to close, as would be the case in this instance, the coexisting ventricular septal defect. But here is a much bigger problem. Here is subpulmonary stenosis produced by a fibrous shelf. And there, as you look up into the roof of the morphologically left ventricle, you can see that diaphragmatic shelf that is narrowing the entrance to the pulmonary valve. And there I've put in the conduction axis. Remember, it runs anterocephalad to pulmonary outflow tract, and you can clearly see that the conduction axis is running within that tissue shelf. Now, we didn't have examples to show you of pulmonary stenosis, but we do have a nice example to show you the extreme form of obstruction of the outflow tract of the morphologically left ventricle, and that, of course, is pulmonary atresia. And when we have pulmonary atresia with congenitally corrected transposition, it can be found with a ventricular septal defect. And then almost always in the setting of congenitally corrected transposition, the pulmonary arterial supply is derived through a persistently patent arterial duct. And Diane now has a nice example to show you of pulmonary atresia with ventricular septal defect in the setting of congenitally corrected transposition.
This heart with congenitally corrected transposition has its apex pointing to the right and has usual atrial arrangement. The aorta and pulmonary trunk, as they exit the ventricular mass, are arranged such that the aorta is anterior and leftward of the pulmonary trunk. You can already appreciate the discrepant size between the aorta and the pulmonary trunk because there was pulmonary atresia in this case. The aortic arch went to the left with usual branching of the brachiocephalic arteries. The branch pulmonary arteries were of good size in this case. There is the right, and the left has been cut, but we can see how large it is as it enters the root of the left lung. The pulmonary arteries were most likely of good size because they were fed by an arterial duct. And also in this case, an aortopulmonary shunt, which has since been taken down during pathologic examination. The atrioventricular connections are discordant in this case, with a morphologically right atrium connected to a morphologically left ventricle. And secondary to the pulmonary atresia, the left ventricle can become very hypoplastic in some cases. It is slightly hypoplastic in this particular case. The mitral valve is supported by paired papillary muscles. There is one, and it's quite interesting that the other papillary muscle in this case is very hypoplastic. There is a ventricular septal defect, and if we check the outlet, we can see that there is indeed pulmonary atresia. So there is no outlet from this right-sided morphologically left ventricle. The left-sided atrioventricular connections are also discordant with a morphologically left atrium, accepting the pulmonary veins, and draining into a morphologically right ventricle on the left side. The inlet is guarded by a tricuspid valve, which actually has gotten torn during examination, but it is attached by tendinous cords to the septal surface and to papillary muscles. The morphologically right ventricle has left-hand ventricular topology, and arising from it is the aorta. So again, discordant atrioventricular and ventriculo-arterial connections. The ventricular septal defect, if we look at it from the right ventricle or the morphologically right ventricle, we see that it is an outlet defect as it lies within the limbs of the septomarginal trabeculation, and it extends to become perimembranous because there is fibrous continuity of the mitral valve and the tricuspid valve along the posterior inferior aspect.
So now you've seen pulmonary atresia with ventricular septal defect in the setting of congenitally corrected transposition. You'll not be surprised to know that we can also have pulmonary atresia with intact ventricular septum. But remember, in congenitally corrected transposition, the pulmonary trunk is arising from the morphologically left ventricle. So because of the discordant atrioventricular connections, when we have this combination, it is the left ventricle that is going to be hypoplastic, and the systemic supply will be from the morphologically right ventricle and the aorta. We have a nice example to show you of pulmonary atresia with intact ventricular septum, and it comes from the Idris archive in Chicago, in the Lurie Children's Hospital in Chicago. So here you will recognize that we're looking at the floor of the morphologically right atrium. And there we have an imperforate mitral valve. So this is coexisting mitral and pulmonary atresia in the setting of congenitally corrected transposition. And there you see the thick-walled, hypoplastic, tripartite left ventricle. There is the undersurface of the imperforate mitral valve, and there you see the very narrowed atretic pulmonary outflow tract leading up to the ventricular arterial junction, which itself is atretic, and there the blind-ending pulmonary trunk. Again, in this instance, the pulmonary arterial supply was through a persistently patent arterial duct, and it is exceedingly rare. Indeed, I have never seen cases of congenitally corrected transposition of pulmonary atresia where the pulmonary arterial supply is through systemic to pulmonary collateral arteries. So that is the second of our trilogy of malformations. The third one is anomalies of the morphologically tricuspid valve. And when a long time ago now we looked at a series of specimens with congenitally corrected transposition, we found such lesions of the morphologically tricuspid valve in 9/10 of the hearts we were looking at. The majority had what we call the Ebsteinoid malformation. It is very similar to Ebstein's malformation in hearts with concordant atrioventricular connections, but it's not exactly the same, and that's why we call it Ebsteinoid. Almost always in this setting, the valval leaflets are dysplastic. You've seen this once already, but Diane's going to show you that heart again. But she's also going to show you a nice example of a straddling and overriding tricuspid valve. And she'll then explain the spectrum that exists from congenitally corrected transposition to double inlet left ventricle with left-sided incomplete right ventricle, which is one of the close cousins. We're not going to have time to show you today malformations of the mitral valve, but remember, they can also straddle and override, and the mitral valve can be cleft. But now, Diane's going to show you the lesions of the morphologically tricuspid valve.
We're going to look at some of the associated malformations that we see in hearts with congenitally corrected transposition. And here we're looking at the left atrioventricular junction so that we have a morphologically left atrium connected to a morphologically right ventricle on the left side of the heart. So discordant atrioventricular connections. The atrioventricular junction is guarded by the tricuspid valve in this case, which you'll see is a bit dysplastic, and as well there is an Ebstein-like malformation, so that we can look at the normal hinge point of the tricuspid valve along the line of my probe, and here you can see the actual hinge point along this portion of the tricuspid valve. It has failed to delaminate, and the hinge point is actually rotated downward. The hearts with congenitally corrected transposition and Ebstein malformation typically do not have atrialization of this portion of the right ventricle, whereas this heart is out of the norm and actually does have thinning of the adjacent ventricular myocardium. So that again we can have valvar dysplasia and hearts with Ebsteinoid malformations associated with congenitally corrected transposition. We've already looked at this specimen with a confluent perimembranous ventricular septal defect, and the point I want to make here is that you can have straddling and overriding of the tricuspid valve in hearts with congenitally corrected transposition. Here you can see some of the tendinous cords attached to the crest of the septum, and there are some that are also straddling the crest of the septum, so that this leaflet is straddling and overriding the crest of the interventricular septum. I also want to point out that you can have this straddling and overriding in such a fashion so that you end up having a double inlet left ventricle. This straddling and overriding is minimal in this specimen. Here we see it from the left side, where you can see the crest of the ventricular septum, and there is the portion of the valve that is straddling and overriding, essentially barely looking into the left ventricle. So as I mentioned, you can have the situation where this valve is looking into the left ventricle in its greater part and moving this specimen towards that of a double inlet left ventricle.
We also don't have any hearts to show you directly that have mirror-imaged atrial arrangement, but we have to remember that congenitally corrected transposition can be found in this setting. And then, of course, because the atrial chambers are mirror-imaged, discordant atrioventricular connections, we're going to have right-handed ventricular topology. So I'm going to show you pictures of another heart, again from the Idris archive, Lurie Children's Hospital in Chicago, which shows congenitally corrected transposition, mirror-imaged arrangement, and right-handed ventricular topology. And in Van Praaghen nomenclature, of course, this is transposition IDD. It is D-loop transposition. The aorta almost always is anterior right-sided, so it is D transposition, but it is still congenitally corrected transposition because there are discordant atrioventricular and discordant ventricular arterial connections. So this is the picture of the right-sided atrioventricular junction, and this is the morphologically left atrium. You see the pectinate muscles are confined within the appendage. You'll then recognize, however, that exiting from this left atrium is the morphologically tricuspid valve, and that is entering the right-sided morphologically right ventricle with right-handed ventricular topology. So turning the ventricle round, there you see the morphologically right ventricle, and you will get the thumb of your right hand through that tricuspid valve, your fingers up the anterior and right-sided aorta with the palmar surface on the septal surface, right-handed ventricular topology in this morphologically right ventricle. Tricuspid valve in the inlet, aorta in the outlet, in this instance with a ventricular septal defect. So when we look at the other side of the heart, because there is mirror-imaged atrial arrangement, the left-sided atrium is morphologically right. And there you see the pectinate muscles extending all the way to the crux. we then have the mitral valve that is entering the left-sided morphologically left ventricle. And then when we look at the morphologically left ventricle, there it is. It gives rise, having received the mitral valve, pulmonary trunk, discordant atrioventricular, discordant ventricular arterial connections. And I'm going to come back to this heart very shortly to discuss with you the conduction tissue in this setting. So we must move on now and we must discuss what is happening with the atrioventricular conduction axis, because we know that conduction problems are a further bad feature of congenitally corrected transposition. And to understand the arrangement of the conduction axis, we have to take into account two features. One of these is ventricular topology, but also important is the alignment between the atrial and ventricular septal structures. And when we have left-handed ventricular topology, it is that septal malalignment that is the rule. And because of that, whenever we have usual atrial arrangement, left-handed ventricular topology, we anticipate an abnormal conduction axis. So you may well be asking, why is that? Well, let's look at the normal heart. This is a look at the aortic root in the normal heart. Just the right atrium, it's connecting to the right ventricle. There is the aortic valve, and in the normal heart, the aortic valve is deeply wedged between the mitral valve and the septum. We know that the conduction axis penetrates through the area of tricuspid to mitral valvar continuity in the posterior inferior margin of this heart, which has a perimembranous ventricular septal defect. There is the deep wedging of the aortic valve, but in the setting of concordant atrioventricular connections, this does not disturb the alignment between the atrial septum and the crest of the musculoventricular septum, so we have a regular conduction axis. But look what happens in congenitally corrected transposition. Here you're looking up into the roof of the right-sided morphologically left ventricle. So there, feeding into the left ventricle, we have the right atrium. There is the morphologically left ventricle, and there is the pulmonary root. And now the pulmonary root is wedging itself deeply between the mitral valve and the septal surface. There is what we call the malalignment gap. And now it's producing malalignment between the atrial septum and the ventricular septum. So now the conduction axis that is carried on the crest of the musculoventricular septum is no longer able to reach the atrioventricular node at the apex of the triangular cock. So instead, in the setting of congenitally corrected transposition, there is a second anomalous atrioventricular node positioned anterosuperiorly with the mitral valvar vestibule, and the conduction axis runs anterocephalad relative to the subpulmonary outflow tract. So now we're going to look at this arrangement in the setting of a heart with congenitally corrected transposition.
It is the role in hearts that have left-hand ventricular topology that there is atrioventricular septal malalignment. So in this heart with congenitally corrected transposition, the pulmonary valve is wedged between the mitral valve and the interventricular septum. So we will have an anomalous conduction axis. The conduction axis will arise where the atrial myocardium joins the ventricular myocardium, so in this anterior superior position, and it will extend anterior superior to the pulmonary valve and then take its normal course over the interventricular septum. This specimen with congenitally corrected transposition has a perimembranous ventricular septal defect, and the conduction axis as well will be abnormal because there is left-hand ventricular topology and atrioventricular septal malalignment. Here we can see nicely where the atrial myocardium joins the ventricular myocardium, so that our atrioventricular conduction axis will be in this area. It will then extend in an anterior superior position to the pulmonary valve, and down along the superior aspect of the ventricular septal defect.
So you've seen what happens when we have congenitally corrected transposition with usual atrial arrangement. Almost always we have that anterocephalad conduction axis. It's not quite the same when we have mirror-imaged atrial arrangement. That means we have right-handed ventricular topology, but if there was septal malalignment, that would not make any difference. But oftentimes, in the hearts that have been studied histologically, there is pulmonary obstruction, and that removes the malalignment gap. And that is why, in most of the cases that have been studied, there is a regular atrioventricular node. And it is certainly possible to have a normal conduction axis, albeit in mirror-imaged situation. And that's what we see in this heart that I've shown you before. You'll remember, this is the heart. It is from the Idris archive in Chicago. The ventricular septum defect happens to show aortic to pulmonary continuity, so it's juxta-arterial. When we look at it from the other side, we see another interesting feature. There is marked pulmonary stenosis, and that has removed the malalignment between the atrial septum and the ventricular septum. There's also a subpulmonary infundibulum. I think there is a little bit of tricuspid to mitral fibrous continuity, but because of the septal alignment, I anticipate that in this particular heart, there would have been a regular atrioventricular node, albeit within the triangle of Koch in the mirror-imaged morphologically right atrium, but the conduction axis will be running posterior-inferiorly in this instance to the perimembranous ventricular septal defect, but is also juxta-arterial. So let's move on. Let's look at the coronary arteries. And the coronary arteries also reflect the ventricular topology. So when we want to analyze the coronary arteries, we look at their sinusal origin, we look at their epicardial distribution, and then we analyze them just as we would in regular transposition. So we consider ourselves as a little mannequin, we place ourselves at the non-adjacent sinus of the aortic root, and we look towards the pulmonary trunk. And then one of the valvar sinuses is going to be to our left hand. So this is number 2. And in the majority of cases, congenitally corrected transposition, because of left-handed ventricular topology, that is going to be giving rise to the morphologically left coronary artery. The other sinus, which is to our right hand, number 1, will be giving rise to the morphologically right coronary artery. And Diane now will illustrate to you this disposition and explain how we recognize right-handed, left-handed sinuses in the setting of congenitally corrected transposition.
We're going to look at the coronary arteries as they are associated with congenitally corrected transposition. And we've already looked at this heart, and we know that it has left-hand ventricular topology. The epicardial distribution of the coronaries will be determined by the topology in each specific heart. Here we know that we have usual atrial arrangement with a morphologically right atrium to the right and a morphologically left atrium to the left. The aorta and pulmonary trunk are virtually side by side in this case, with the aorta slightly anterior and to the left of the pulmonary trunk. I'm going to tilt the heart up on its apex so that we can look down into the aortic and pulmonary trunks. So this is the aorta, this is the pulmonary artery. You can see the bifurcation to the left and right, main pulmonary arteries. So what I'm going to do is effectively stand in this non-adjacent sinus within the aorta. So the sinus that's farthest away from the pulmonary trunk, so that this sinus and this sinus are the adjacent sinuses. This non-adjacent sinus is what some people call the non-coronary sinus, because it very rarely gives rise to a coronary artery. So if I'm standing in this non-adjacent sinus, my right hand will go towards the right-facing sinus, or to sinus number 1. My left hand will go towards the left-hand facing sinus, or sinus number 2. So that when we look at the coronary orifices as they exit the aortic root, we can see one in sinus number 2 and one in sinus number 1. So these are the sinuses adjacent to the pulmonary trunk. If we look at the coronary artery arising from the right-hand facing sinus, or sinus number 1, we can see that it is morphologically consistent with a right coronary artery. And this is the typical pattern when you have usual atrial arrangement, so that the right coronary artery will arise from the aorta and give rise typically to an infundibular branch, and what some people call the conal branch, and then the right main coronary artery will encircle the tricuspid valve orifice, or run within the left atrioventricular groove. This coronary artery usually gives rise to the inferior interventricular coronary artery, and in this case gives rise to a few small branches that track over the left ventricle, which is right-sided in this case. So dominance is typically decided on which coronary artery gives rise to the inferior interventricular branch. If we move to the other coronary arising from the left-hand facing sinus, or sinus number 2, we see that there is a short main trunk, and it immediately branches into the anterior interventricular coronary artery and a circumflex branch. The interventricular coronary arteries, both anterior and inferior, give a good indication of where the ventricular septum is located. The circumflex artery continues into the right atrioventricular groove, or surrounding valve orifice. So here it extends and actually becomes very fine at its termination over the anterior wall of the right-sided morphologically left ventricle, so that in this case we can clearly see that the right coronary artery was dominant, as it gave some branches to the inferior aspect of this morphologically left ventricle that is right-sided, and it also gave rise to the inferior interventricular artery.
So before we move on and look at the close cousins, let me come back to one point, because I'm sure many of you still call congenitally corrected transposition L transposition. Is that justified? Absolutely not. Because when we have congenitally corrected transposition, the aortic root is not always left-sided. I've already shown you that when we have mirror-imaged arrangement, the rule in transposition IDD is to find D transposition, but the D transposition is not congenitally corrected. But on the other hand, we can have L transposition, as we see in transposition SDL, and now, because of the concordant atrioventricular connections, this is regular transposition. So L transposition is not the same as congenitally corrected transposition. We should also remember we can have abnormal ventricular positions. Oftentimes the ventricular mass is tilted, giving us supero-inferior ventricles. We can rotate the ventricular mass, giving us twisted atrioventricular connections, or the crisscross heart. And you'll remember last week we discussed how that twisting does not change ventricular topology. So we don't have time to revisit that feature. So we want to finish by sharing with you the close cousins. We can have discordant atrioventricular connections with other ventricular arterial connections. So Diane's going to show you an example with double outlet right ventricle. We can have isomeric appendages with left-handed ventricular topology. And most also, we can have double inlet left ventricle, and the incomplete right ventricle is anterior and right-sided. So Diane now is going to show you the...
We're looking at the short axis from the base of a heart that is a close cousin to congenitally corrected transposition. This heart was transplanted, that's why we don't have the atrial chambers and the arterial trunks. From this aspect, we see the aorta arising directly anterior to this very large pulmonary trunk, and we know that we have usual atrial arrangement with a morphologically right atrium and appendage to the right, and a morphologically left atrium and appendage to the left. If we look at the right atrioventricular junction, we see that it is guarded by a morphologically mitral valve that has only papillary muscle attachments and no attachments to the interventricular septum. The right-sided ventricle is a morphologically left ventricle with fine crisscrossing apical trabeculations and a smooth septal surface towards the outlet. So we have discordant atrioventricular connections. You'll also note that there is a very large ventricular septal defect. The mitral valve straddles and overrides this ventricular septal defect and also has a true cleft, so that this cleft points directly at the outflow tract rather than at the interventricular septum. There is no outlet to this morphologically left ventricle on the right side, and this heart does have a double outlet right ventricle. We'll see that in a moment. On the left, we have a morphologically left atrium and atrial appendage. The atrioventricular junction guarded by a dysplastic tricuspid valve. You can see it has a curtain-like posterior most leaflet that is somewhat thickened, and there is also an Ebsteinoid malformation along the inferior aspect. I apologize for the heart falling apart, as it was improperly sectioned initially, and I've tried to glue it back together. So here we have the Ebsteinoid component of this tricuspid valve, where the true hinge point would be here, and you can see where this portion failed to delaminate. The ventricle on the left side is a morphologically right ventricle with its coarse apical trabeculations. As well, you can see the septal attachments of the tricuspid valve and the papillary muscle attachments. The outlet to this left-sided morphologically right ventricle has the aorta supported by a complete muscular infundibulum, and as well there is the pulmonary artery exiting this ventricle. So there is a double outlet right ventricle with discordant atrioventricular connections. Also, the mitral valve is straddling and overriding this ventricular septal defect with a large papillary muscle towards the outlet and smaller papillary muscles within the left-sided right ventricle. So there's the crest of the ventricular septum, and you can see this component of the mitral valve straddling and overriding the ventricular septum. I will mention in this heart that because of the double outlet right ventricle, the atrioventricular septal malalignment is not as severe, and the atrioventricular septum is a bit more aligned, so that the ventricular septum is reaching the crux of the heart in this particular case, which may allow the conduction axis to form in a more normal or usual position. Also, I'll note that there is a fibrous component here created by the tricuspid and the mitral valve, so that this is a perimembranous ventricular septal defect. This specimen is quite complex, and I'm sure we'll review it more completely when we discuss the isomerisms. You'll note that the apex is pointing to the right, and when we view the arterial trunks as they exit the ventricular mass, it looks as though they're side by side with the aorta to the left of the pulmonary trunk. Looking inside of this left-sided ventricle, we see that it is morphologically right with coarse apical trabeculations, and there is also left-hand ventricular topology, so that only the palm of my left hand can be placed on the septal surface with my thumb in the inlet and my fingers in the outlet. The pulmonary trunk arises from this ventricle and is supported by a complete muscular infundibulum. If we look at the right-sided ventricle, it is morphologically left with fine crisscrossing apical trabeculations and some degree of so-called non-compaction as well. The outlet is severely stenotic, and arising from it is the aortic valve. So you can see one of the leaflets between my forceps. So this shows us that the aorta does spiral out from behind the pulmonary trunk in mirror imaged fashion. And this also is consistent with what we've already seen, namely the right-hand ventricular topology. So this right-sided ventricle is connected to a morphologically left atrium with its tubular appendage and narrow attachment to the venous junction. There is a superior cable vein entering its roof and no identifiable terminal crest. The pulmonary veins also enter this right-sided morphologically left atrium. If we look at the opposite atrium or the left-sided atrium, it too is morphologically left with a tubular appendage and a narrow attachment to the venous junction. The venous component is composed of a superior cable vein entering its roof with no identifiable terminal crest, and the hepatic veins entering the floor. So this specimen demonstrates isomerism of the left atrial appendages, but also with mirror imaged arrangement of the veno-atrial connections, so that the flow of blood through the heart is physiologically correct despite the multiple malformations. This heart is an example of a double inlet left ventricle, and if I lift the anterior half off, I can quickly show you that with the right atrium and the right atrioventricular valve and the left atrium and the left atrioventricular valve connected to this dominant morphologically left ventricle. In anterior superior position, we have a rudimentary and incomplete ventricle that is lacking its inlet. It has an apical trabecular component that, if we look inside the ventricle, shows us there are coarse trabeculations consistent with a morphologically right ventricle. Within the outlet is the aortic valve, and the aortic root is supported by a complete muscular infundibulum. The only inlet to this rudimentary and incomplete ventricle is the interventricular communication. So using that interventricular communication as our inlet, this ventricle will only permit the palm of my left hand to lie on the septum with my thumb in the inlet and my fingers in the outlet, exhibiting left-hand ventricular topology. So this is an example of segmental disharmony because there is usual atrial arrangement along with left-hand ventricular topology. But we must remember that the atrioventricular connection is one of a double inlet. Here we can see the usual atrial arrangement with the right atrium, the morphologically right atrium to the right, and the morphologically left atrium to the left. In the system initially used by Dr. Van Praagh, this specimen would be designated as having discordance. But the heart does not have discordant atrioventricular connections, since the left atrium has retained its connection with the dominant morphologically left ventricle, so that we can confirm that this heart does have a double inlet left ventricle with the morphologically left atrium maintaining its connection with the morphologically left ventricle. This heart is a close cousin of congenitally corrected transposition in the terms of ventricular topology. Remember, we said it had left-hand ventricular topology. but it is different with regard to the atrioventricular connections, which we also demonstrated are that of a double inlet left ventricle.
I should mention one other close cousin before we finish. We don't have a heart of this type to show you, but the combination of discordant atrioventricular connections and concordant ventriculo-arterial connections is particularly important because that will produce the circulatory pattern of regular transposition. And it's important because surgical correction for this lesion will be by redirecting the atrial returns. So in this setting, the surgeons will be doing a Senning or a mustard procedure. The key feature is that despite the concordant ventriculo-arterial connections, the arterial trunks leave the heart and enter the mediastinum in parallel fashion. And so that is how I like to describe this: concordant ventriculo-arterial connections with parallel arterial trunks. It's not always easy to recognize it. This is another heart from the Idris archive from Lurie Children's Hospital in Chicago. And when I first saw this heart, I thought this was just a regular congenitally corrected transposition. There is the right-sided morphologically left ventricle, and initially I had thought that the pulmonary trunk was arising from the ventricle, but in fact it is the aorta. And you see, when we look at it very closely, there is discontinuity between the leaflets of the aortic valve and the mitral valve. There is a coronary artery arising from the arterial root, telling us that it is the aorta. So this is discordant atrioventricular with concordant ventricular-arterial connections. The arterial trunks have been cut short, but when they were leaving the heart, they were ascending into the mediastinum in parallel fashion. There is mitral to tricuspid continuity. We'd be assessing the defect from the other side, but we know it is perimembranous. And because in this instance there is septal malalignment, there is an anterocephalad conduction axis relative to the aortic root. So what we've tried to do is we've tried to put into practice what we told you about sequential segmental analysis. And what you've seen today, when we analyze congenitally corrected transposition, first we work out what's going on in the segments, and then we note how they are joined together. And it is the abnormal connections that are the key to this lesion. The two discordant connections cancel each other out, and that is why we have the congenital correction of the circulation. We should not infer one feature on the basis of another, and nowadays you don't need to do that because you can see this anatomy just as well in the clinical setting as we can when we have the hearts in our hands. But remember, it is the fashion in which the chambers and arterial trunks are joined together that determines the way the blood goes around, and that is why our emphasis needs to be on the discordant connections between the cardiac segments.
Okay, Bob. So we have Norman ready for some comments. Is a real triumph of the approach, of the sequential approach? What do you think, Norman?
Well, it is a triumph, and certainly there's a lot in here that is very important in terms of the conducting tissue. But Bob, the one problem that an echocardiographer will have is the way that we look at the great vessels when we image them. Because you as an anatomist, or Sasha as a surgeon, would look from above, okay? And we as echocardiographers would look at the heart from below. So that kind of messes up the right and left-hand pattern. And the only solution for an echocardiographer then is to pretend that he's looking at this upside down and get the right and left-hand pattern of the coronary arteries organized. And I didn't realized this for a long time. And if you look at echocardiography literature, you'll find that they describe them as coming from which sinus rather than the handed pattern. And that sort of messes up the whole of the Leiden convention. The only other thing about the coronary arteries that is important, and Diane had shown this beautifully, and you'd mentioned this too, is that you can really look at the coronary arteries and their early branching pattern to define which is the right, morphologically right coronary artery and morphologically left coronary artery. And that helps you sometimes looking at the ventricular patterns. And I put this in the app that we've put down together. So those are 2 points. Perhaps you'll comment on that. I do have some other comments when you're finished. So please try and answer that for me.
Well, to an extent, I think I had presumed that you would all be sufficiently agile to realize that although you're echoing the heart upside down, having echoed it upside down, surely you are sufficiently agile to put it back in your head the right way up. And then think of the aortic root when you're looking down on it.
It requires an effort. Yes, I think you can do that, but it's something that was, I think, not appreciated. And so that's why they've eschewed in the echocardiography literature to describe the coronary arteries using the Leiden convention. In a way, that's a bit. It's interesting that there is an article that has just appeared. I think it's in the European Journal of Cardiothoracic Surgery. And it's from the Leiden group, and it includes the late Adriana Schittenberger de Groot, who sadly passed on a few months ago. And they cater for this, and they show how you have to, as you say, invert yourself. But I think the point to make, as you say, is that once you recognize that you have to put the heart the right way up before you distinguish between the sinuses. The whole point of the thing is simply to distinguish between the two sinuses that are adjacent to the pulmonary root, And if you think of them as sinus 1, sinus 2, then so be it. I mean, my problem was I always forgot which was sinus number 1 and which was sinus number 2. And as I've commented many times, thus far, I haven't forgotten which is my right hand and which is my left hand. Correct.
So that is why I prefer that way of looking at things. And of course, the surgeon is perfectly positioned because the surgeon can put himself directly into the root. So I think this is one of the things where the echocardiographer has to try that extra little bit and help the surgeon so that he or she knows what's going on, because I don't think it invalidates the Leiden Convention. Next week, in fact, we're going to discuss regular transposition, and we'll go into this again. So the same problem will arise next week. So Diane next week, and Diane's listening to this, so she can tell you, she can show how you have to be standing upright in the non-adjacent sinus. And so figuratively speaking, you have to, as you say, rotate yourself around. You have to turn yourself upside down from echocardiographic stance so that you are standing upright with the heart in its regular position.
Sure, and I think that this is very interesting because when making echomorphological correlations, it's easy when you look at sagittal plane or apical plane images to match this with the heart. But when you're looking at short axis imaging, the left hand and right hand patterns are totally different from echo and morphology, because echo looks at things from below upwards and morphology looks at things from above downwards.
And I think the surgeon also looks at things from above downwards,
correct.
Because that's the way the surgeon opens the chest and gets in there. I mean, I accept that it's a problem because it's also the way that we look at three-dimensional data sets. So when we're looking at computed tomograms, when we illustrate those, we look at the short axis from beneath rather from above. So I think all we have to do is to remember that we have to twist ourselves round, and if you like, we have to do a somersault. So that we're looking at it from the other way around. And
correct.
So, and
it's an
in the
important
paper
point,
that the Leiden group have just published in the European Journal, they are showing this little figurine who looks remarkably like the late Adriana. And so she's doing a little somersault. So she's getting the right way around.
Well, good for the Leiden group. Bob, when I came to London,
well, just
a minute. One of the important things in London is if you take the tube, it always says mind the gap. And I would like you to spend some time.
Well, Alan was going to make a Alan, want to make a comment on the coronary arteries?
just a few things. Basically,
It's your
I've
dog.
always struggled with the Leiden Convention. Just close the door.
So while he's doing that, Bob, I want you to reiterate this bit about the gap.
We'll come on to that. He's back again now.
The dog doesn't like your voice. Basically, I've always struggled with the Leiden Convention. I think it's a good thing to put out the message that cross-sectional imaging and echo look at the images from beneath. I think it caused a lot of confusion in people because the Leiden Convention I always found very difficult for the reasons just given. It's a good message to put across. I think a couple of other things. We didn't really talk very much about how to deal with these lesions, obviously, and there's a whole different topic in itself, how to treat CCTGA, because there's used to be so much debate about this in terms of physiological anatomical correction. I think that's largely passed, but there's still a lot of problems about treating these patients in the real world. That's a whole different topic in itself. And the only other thing I want to say is I've never seen AV discordance with VA concordance in my life. Some amazing cases. Incredible. And just one other comment is the importance of convention. I think the 2 points about convention is that considering topology from the surface of the septal surface of the right ventricle, and also thinking of the VSD from the septal surface of the right ventricle is very important points, because to be consistent in these issues, very important.
Sure. Alan, let me just add some little perspective on your comment. I have seen 2 patients with what used to be called isolated ventricular inversion. These patients present without ventricular septal defects, present like a cyanotic transposition.
Okay.
And I think, so again, if you apply sequential segmental analysis to your echocardiograms, you can come up with the fact that there is a discordant atrioventricular connection with concordant ventricular arterial connections. And I think that's important. I mean, I don't think the surgeons will get fooled when they have to go in and operate on these patients, but I do think that you can sort this out very easily. And when I think back of my career, I've only seen two cases of this. The first one was published from our institution when I was doing a sabbatical with Bob Anderson by my colleague Rebecca Snyder. And this patient presented as a typical transposition, blue baby without any problems, but the ventricles had a discordant atrioventricular connection. So again, I think this enforces Bob's idea of the fact that you must do everything in a systematic fashion with the sequential analysis.
And the point you make there, Norman, is a very important one. You mentioned isolated ventricular discordance or isolated ventricular inversion. In fact, next week, we're going to discuss the problems that arise in this regard. So we'll come back to this entity next week when we talk about regular transposition. Because as you say, the circulatory patterns produce regular transposition. You have to be aware of what's going on, because in the setting of the discordant atrioventricular connections, the conduction system is going to be in a totally different position. And if you find them with a ventricular septal defect, as in the one I showed from the Lurie archive, the conduction axis will be anterior in the setting of the discordant AV connections, even though the patient is presenting seemingly with regular transposition.
Right. So Bob, before I sign off with my comments, if you would just perhaps I think we can go back and look at the thing on YouTube, today's presentation. But this gap that you describe is a sort of a new finding as far as I'm concerned. And I wonder whether you would reiterate the issues related to the gap.
It's simply the fact that when the pulmonary route in congenitally corrected transposition wedges itself between the mitral valve and the septum, it shifts the atrial, it produces a shift between the atrial septum and the ventricular septum. And it's that shift produced by the wedging of the pulmonary trunk that means that the conduction system carried on the crest of the ventricular septum can no longer reach the regular atrioventricular node, which is at the apex of the triangle of Koch. And it's there, it's in the apex of the triangle of Koch, but it's the malalignment gap, as you say, mind the gap. It's that wedging, which Diane showed you beautifully in the case with the intact septum, and it's also there in the cases with the ventricular septal defect. But if you don't have that malalignment, and you don't have that when the pulmonary trunk arises from the morphologically right ventricle, as in the case that Diane showed you with double outlet right ventricle, you don't have that when you have severe pulmonary stenosis or severe pulmonary atresia. So potentially, also in the cases with usual atrial arrangement in pulmonary atresia, there could be either a sling or a regular conduction system. And I mean, these are the things that we haven't explored at any great depth, because to find the conduction system in the past needed serial histologic sectioning. Nowadays, we're going to be able to do this using synchrotron imaging or micro CT. So one of the things we're hoping to do with the Birmingham archive is we're hoping to look at more of these, because you can now find the conduction system without having to destroy the hearts. So the variations that might exist with the conduction system in congenitally corrected transposition have still to be determined with certainty.
I just read a paper in the World Journal of Cardiology about some dye that you can put into the heart that will allow the recognition of the conducting tissue visually, so that would aid the surgeons in being able to define what's going on.
I remain to be convinced of the validity of that. It's a very, I don't think it's something that you see. You have to do it with a probe, do you not? Because, and I think I think you do it, and they're working on it between Utah and Boston Children's Hospital. And, but I remain to be convinced that that will take on.
There is a good question for, I think for Bob, or some clarification about what is Ebsteinoid, what is Ebstein in terms of tricuspid valve?
It is indeed a good question. I've always simply called it Ebstein's malformation. The point has been made that when Ebstein described his first case, he did it in the setting of concordant atrioventricular connections. So it's questionable whether we should discuss it. And the questioner is asking whether there is always thinning of the inlet. And in fact, we know that in the minority of cases, do you have thinning or anatomic atrialization? Diane showed you her case in which there was anatomic atrialization. And I've seen only one case in which there's been a full-blown Ebstein malformation with linear attachment to the anterosuperior. Oh, and also, Diane made a very good point. We call it the anterosuperior leaflet. In Ebstein's malformation, of course, it's the posterior-inferior leaflet, which was another very nice point she made in her demonstration. So I think we have to be, so it's not exactly the same, but it has sufficient things in common that, so we call it Ebsteinoid, recognizing that it's not exactly the same as what Wilhelm Ebstein described way back when he was working, when he saw the heart of Joseph Prescher.
Diane, you want to say something?
No, I don't think so. I have one historical point that Bob might be interested in. And Baron von Rokitansky was a pathologist, and in the autopsy room, we use a type of evisceration that is named after him. So just a historical point.
Yes, that is important. Bob, there is a fantastic question from Paolo Zelischi. I know that he follows us every week. If you want to make some comments about the question.
What is the question?
In normal atrioventricular and ventricular arterial connection, it has been shown that subaortic fibrous ridge may be secondary or related malalignment VSD. Could the subpulmonary fibrous shelf in corrected transposition also be related to malaligned VSD?
That's a very good question.
Yes.
As you say, Paolo usually asks us very interesting questions. It's a very interesting question. And I've not really thought of it in that regard. He's probably in a better position to answer that than I am. It was also very interesting in the heart that Diane showed you, the first heart she showed you with that central defect, because there was a very well-formed muscular outlet septum beneath the pulmonary root, which it was a very small defect. As she said, it was a central defect, but it wasn't malaligned. And though, Diane, there wasn't pulmonary obstruction in that heart, was there?
No, there was not.
So it's very interesting, because in the heart that I did show, though I showed the picture of it, where there was that extensive subpulmonary shelf, I think there probably was malalignment of the outlet septum. It's something I've never looked at before. So it's a very interesting point that Paolo makes. Norman, do you'd be able to see the malalignment echocardiographically?
I haven't noted that, Bob. But I'm sure that Paolo is right that there is an issue there.
It's all of these things. As we have these sessions, the questions come up and we don't know the answer to them. So there are still so many things that we still need the answers. And these are the sort of things that people should be looking at now and thinking. And when they see new cases, I mean, increasingly, goodness me, you've got something the matter with your eye, Norm.
Yeah, sorry, Bob.
That was a nice view. Everybody saw a little bit of you putting a little drop in your eye there.
Well, there you go. It's feeling better now.
But
I've got a bit of conjunctivitis.
These are the sort of things that the questions are arising. We still get lots of case reports. Series are always much better than case reports. So people should be looking at their series of hearts with congenitally corrected transposition. Paolo must have a big series. I mean, he's been working in Porto Alegre now for a long time. He must have a good series of cases he could look at in his own right.
We will contact him. We will invite to show some case from Porto Alegre. What do you think?
Can I ask one more question? Bob, is there a difference between the conducting tissue access in the normal atrial arrangement and that with mirror image dextrocardia?
Allegedly, but then again, this is the problem that I alluded to. It was initially suggested that if you had congenitally corrected transposition with right-handed ventricular topology, because you had right-handed topology, you would have a regular conduction system. But in fact, that is not always the case. And it comes back to the malalignment gap once more. And it was Reza Hosseynpour, who is the surgeon who now works in Valencia. He's Iranian initially. He came and he spent some time working with us at the Brompton Hospital. And he looked through all the hearts that had been studied with mirror image derangement, corrected transposition, that had had histologic studies. And he noted that in all the cases in which people had found regular conduction systems, there was either pulmonary atresia or there was severe pulmonary stenosis. And so that had removed the malalignment gap. So, and it's still the case, to the best of my knowledge, there has not been a case reported in the literature of mirror imaged corrected transposition without that malalignment gap. The case I showed from the Lurie Hospital also had severe pulmonary stenosis. So this again is something that we need to look at. But I am sure that in the cases where there is that malalignment gap, you will have a regular conduction, you'll have an anterior conduction system arising from an anterior node in the left-sided morphologically right atrium. I say that off the top of my head. It's something else we need to check up on.
Okay, so we are 4:30, 1 hour 30. We are very happy. We would like to thank all the people who was with us. If Bob would like to introduce the next week and then the future speech, we will be happy.
Indeed. So next week, we're going to move on and we're going to look at regular transposition. And we're also going to do this in 2 stages. So in the first stage next week, we're going to discuss the problems that have arisen because during my lifetime, transposition, and during Norman's lifetime, Norman will know this very well, transposition has been a remarkably contentious entity, and it's all down to the nomenclature, the way we describe it. So next week, we're going to discuss the problems that previously existed. Nowadays, I think we have cured those problems. So now I think it is very easy to understand regular transposition. It is concordant atrioventricular connections with discordant ventricular arterial connections. So next week, we're going to discuss the problems that have existed, and I'll explain how we've resolved those problems. And then in 2 weeks' time, as we have done today, Diane is going to show all the variations that you find, and we're going to come back to the coronary arteries, and we'll try to explain how, as echocardiographers, you need to somersault yourselves up so that you can stand in the non-adjacent sinus and look towards the pulmonary trunk. So Diane will have to think now as to how she can show us somersaults. She was a gymnast in her youth, so she knows all about somersaults. So next week, Diane, you need to tell us how we somersault around so the echocardiographers can look at the arterial routes the right way up.
Okay.
I'll see if I can figure it out.
Okay.
And Norman, you'll have to think also how you can somersault yourself up so that you're looking at it the right way around. Alan has also said it's a problem. So we're going to have mental gymnastics next week, even if we don't have physical gymnastics.
It's not a problem when you recognize that and Bob, there is a quick route around this for the coronaries, is instead of saying sinus number 1 comes from your right hand, you say sinus number 1 comes from your left hand, and then we have the convention normal.
Right. That's made that for me, that makes it even harder. So but Diane will do mental gymnastics for us all next week.
Okay.
Great. Look forward to it. Thank you very much.
Thanks to everybody. Thanks to Alan being with us again. And we look forward to seeing you all again next week.
All right.
Thanks
Very
so much.
Hi, Alan. Bye, David. Norman.
Hi.
Goodbye.
I just wanted to say our session went awesome
Oh,
at the anatomy meeting.
you disappeared there for a moment, David. I know
I
you and Shumpei and Diane were hard at it yesterday, so I hope it was well appreciated.
I think so. Let me see if I can do this. Maybe not.
You have to share your screen, Dave.
Yeah, I'm trying. But I'm not getting a good, anyway, I had a picture of all of us. It's the Brady Bunch.
Ah,
But it went really well. I heard some good comments about it, and it's a beginning. Now we need to follow up by doing something.
and you're 100% right, because we've got to start this education from the medical students. We've got to educate the medical students from the word go, make it, if they find it simple to understand, then hopefully we'll all find it simple to understand.
So hopefully Diane is willing to work with me and we can put something together like a lab guide.
Absolutely. And it will be invaluable for everybody else.
Good.
Thank you very much. Bye,
Thanks.
David.
Thanks, David.
Bye.
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 Well, thank you very much, everybody.
Bye, Norman.
I know.
Bye.